Hello, my name is Eric Michael Lloyd. I have a master's in psychology, neuropsychology concentration. I wanted to read an article called Psychological Interventions for Antisocial Personality Disorder. This one is by Cochrane Database System Review, or Systematic Review, 2010, issue volume number 6. This was the author manuscript, and the numbers that come after are CD007668. The Cochrane Database for Systematic Reviews. That's how you say that. The title is Psychological Interventions for Antisocial Personality Disorder, and this was written by the authors Simon Gibbon, Connor Dugan, and Klaus Leib. There's also more authors that are written in here, as there's ellipsis. More authors. Abstract. Background. Antisocial Personality Disorder, ASPD, is associated with a wide range of disturbance, including persistent rule breaking, criminality, substance use, unemployment, homelessness, and relationship difficulties. To evaluate the potential beneficial and adverse effects of psychological interventions for people with ASPD, those are the objectives. Search methods. Our search included Central Register of Controlled Trials, Medline, Embase, Sanal, PsycInfo, Asia, Biosis, and COPAC. Selection criteria: prospective controlled trials in which participants with ASPD were randomly allocated to a psychological intervention and a control condition, either treatment as usual, waiting list, or no treatment. Data collection and analysis. 3 authors independently selected studies. 2 authors independently extracted data. We calculated mean differences, those are average differences, with odds ratio for dichotomous data. Main results. 11 studies involving 471 participants with ASPD met the inclusion criteria. Although data were available from only 5 studies involving 276 participants with ASPD, only 2 studies focused solely on an ASPD sample. 11 different psychological interventions were examined. Only 2 studies reported on reconviction and only 1 on aggression. Compared to the control condition, cognitive behavioral therapy plus standard maintenance was superior for outpatients with cocaine dependence in 1 study, but CBT plus treatment as usual was not superior for male outpatients with recent verbal or physical violence in another. Contingency management plus standard maintenance was superior for drug misuse for outpatients with cocaine dependence in 1 study, but not in another, possibly because of differences in behavioral intervention. However, contingency management was superior in social functioning and counseling session attendance in the latter. Counseling session attendance was a factor. A multi-component intervention utilizing motivation interviewing principles. A multi-component intervention utilizing motivational interviewing principles, the driving whilst intoxicated program, plus incarceration was superior to incarceration alone for imprisoned drink driving offenders. Author's conclusions. Results suggest that there is insufficient trial evidence to justify using any psychological intervention for adults with ASPD. Yikes. Disappointingly, few of the included studies addressed the primary outcomes defined in this review: aggression, reconviction, global functioning, social functioning, adverse effects. 3 interventions: contingency management with standard maintenance, CBT with standard maintenance, driving whilst intoxicated program with incarceration, appeared effective compared to the control condition in terms of improvement in at least one outcome in at least one study. Each of these interventions had been originally developed for people with substance misuse problems. Significant improvements were mainly confined to outcomes related to substance misuse. No study reported significant change in specific antisocial behavior. No study reported significant change in any specific antisocial behavior. This is as of 2010, so we could be cautiously optimistic. Just report the findings as they are. Further research is urgently needed for this prevalent and costly condition. Medical subject headings. MESH, aggression psychology, antisocial personality disorder and therapy, cocaine-related disorders and therapy, cognitive therapy methods, psychotherapy methods, randomized controlled trials as topic. Reward, MESH, check words, adult, female, humans, and male. Background. Description of the condition. Antisocial personality disorder, ASPD, is one of the 10 personality disorder categories in the current edition of the Diagnostic and Statistical Manual of Mental Disorders, DSM-4, APA 2000. DSM-4 defines personality disorder as an enduring pattern of inner experience and behavior that deviates markedly from expectations of the person's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment. Read that one more time. Personality disorder is defined as an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the person's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment. General criteria for personality disorder according to the DSM-4 are given in Table 1 below. ASPD, antisocial personality disorder, identified by trials that include irresponsible and exploitative behavior, recklessness, impulsivity, high negative emotionality, and deceitfulness. In order to be diagnosed with antisocial personality disorder, ASPD, according to the DSM-4, a person must fulfill criteria A, B, C, and D shown in Table 2 below, as well as fulfilling general criteria for a personality disorder as outlined above. The focus of this review is antisocial personality disorder, although this condition is also often classified using the International Classification of Diseases, 10th edition, ICD-10, WHO, or World Health Organization as it's known, 1992, as dissocial personality disorder. F60.2, ASPD and dissocial personality disorder are often used interchangeably by clinicians as they describe a very similar presentation. While there is a considerable overlap between these two diagnostic systems, they differ in two respects. First, DSM-4 requires that those meeting the diagnostic criteria also show evidence of conduct disorder with onset before the age of 15 years, and there is no such requirement when making the diagnosis of dissocial personality disorder using ICD-10 criteria. However, a study by Perticori et al., Perticori 2007, did not find any clinically important differences when they compared subjects meeting the full criteria for ASPD with those who otherwise fulfill criteria for ASPD but who did not demonstrate evidence of childhood conduct disorder. Second, dissocial personality disorder focuses more on the interpersonal deficits, for example, incapacity to experience guilt, a very low tolerance of frustration, proneness to blame others, and less on antisocial behavior. Table 3 below shows the diagnostic criteria for diagnosing dissocial personality disorder. Second, it has been argued that the criteria in ICD-10 are more reflective of the core personality traits of the antisocial, with less emphasis on criminal behavior. Whilst estimates of the prevalence of ASPD in the general population vary across studies and countries, most studies report a prevalence of between 2% and 3% in the general population. Coyd, 2006, Moran, 1999. Prevalence rates are consistently higher in men. Prevalence rates are consistently higher in men than in women, or compared with women. Dolan, 2009. For instance, the lifetime prevalence in 2 North American studies was 4.5% among men and 0.8% among women. Robbins, 1991, and 6.8% among men and 0.8% in women. Swanson, 1994. However, 2 European studies found lower prevalence rates, i.e. 1.3% in men and 0% in women. Torgensen, 2001, and 1% in men and 0.2% in women. Coyd, 2006. As would be expected, ASPD is especially common in prison settings. In the UK prison populations, the prevalence of people with ASPD has been identified as 63% in male remand prisoners, 49% in male sentenced prisoners, and 31% in female prisoners. Singleton, 1998. The condition is associated with a wide range of disturbance and is associated with greatly increased rates of criminality, substance use, unemployment, homelessness, and relationship difficulties. Antisocial personality disorder is generally associated with a negative long-term outcome. Many adults with ASPD are imprisoned at some point in their life. Although follow-up studies have demonstrated some improvement over time, particularly in rates of reoffending, Grillo, 1998, Wiseman, 1993, men with ASPD who reduce their offending behavior over time may nonetheless continue to have major problems in their interpersonal relationships. Paris, 2003. Black found that men with ASPD aged less than 40. Black found that men with antisocial personality disorder aged less than 40 years had a strikingly high rate of premature death and obtained a value of 33 for the standardized mortality rate, the age-adjusted ratio of observed deaths to expected deaths, meaning that they were 33 times more likely to die than similar males of the same age without this condition. Black, 1996. This increased mortality was due not only to an increased rate of suicide, but was also associated with reckless behaviors such as drug misuse and aggression. Follow-up studies in forensic psychiatric settings suggest a similarly concerning picture. For example, Davies, 2007, reported that 20 years after discharge from a medium secure unit, almost half of the patients were reconvicted, with reconviction rates higher in those with personality disorder compared to mentally ill patients. Significant comorbidity exists between ASPD and many Axis I disorders. Mood and anxiety disorders are common, although most frequent co-occurrence is with substance misuse. Men with ASPD have been found to be 3 to 5 times more likely to abuse alcohol and illicit drugs than those without the disorder. Robbins, 1991. The prevalence of personality disorder co-occurring with an Axis I condition may have a negative impact on the outcome of the latter. Newton Howells, 2006. Scotto, 2005. Description of the intervention. Psychological interventions have traditionally been the mainstay of treatment for ASPD, but the evidence upon which this is based is weak. Dugan, 2007. NIHCE, 2009. Psychological therapies encompass a wide range of interventions. Bateman, 2004, but may be broadly classified into four main categories: psychoanalytic psychotherapy, cognitive behavioral, therapeutic community, and nidotherapy. Traditionally, psychoanalytically based psychological therapies held sway, but latterly these have been replaced by more cognitive behavioral therapy-based approaches. Cordes, 1996. It is important to consider all relevant studies without restriction on this type of psychological therapy and to consider psychological interventions where drugs are also given as an adjunctive intervention. How the intervention might work. Psychoanalytic therapies, which include dynamic psychotherapy, transference-focused psychotherapy, mentalization-based therapy, and group psychotherapy, aim to help the patient understand, and these therapies help the patient to understand and reflect on his inner mental processes and make links between his past and current difficulties. To our knowledge, no randomized trials have been published assessing the efficacy of dynamic psychotherapy specifically for ASPD, but there are a small number of trials which examine the effectiveness of psychoanalytic therapies for personality disorder in general. Limited evidence for the efficacy of psychodynamic psychotherapy comes from Bateman, 2001, Chesa, 2003, Piper, 1993, and Winston, 1994. Cognitive behavioral therapy, CBT-based treatments, place emphasis on encouraging the patient to challenge their core beliefs and to gain insight into how their thoughts and feelings affect their behavior. A review of the evidence for this form of intervention concluded that the overall evidence in favor of cognitive behavioral therapy in the treatment of personality disorder is therefore relatively slim, with much of the evidence coming from one research group, but it has involved more patients than any other form of treatment. Bateman, 2004. DBT, dialectical behavioral therapy, is a complex psychological intervention which was developed using some of the principles of CBT, Linehan, 1993, and may help change behavior by improving skills and the ability to contain difficult feelings. It is currently popular, but the evidence for its efficacy is less clear, with some reviewers considering that its only proven benefit appears to be in the reduction of self-harm episodes. Bateman, 2004. Cognitive analytic therapy, CAT, is a brief psychological therapy utilizing ideas from psychodynamic psychotherapy, cognitive therapy, and cognitive psychology. Denman, 2001. Therapeutic community treatments involve patients, also known as residents, not only having therapy together, but also working and living together in a shared therapeutic environment. This provides them with an opportunity to explore intrapsychic and interpersonal problems and find more constructive ways of dealing with distress. Campling, 2001. Therapeutic community treatment is the only single treatment modality for severe personality disorder, which is likely to encompass ASPD and some other forms of personality disorder, that has been subject to a meta-analysis of randomized controlled trials. This demonstrated the effectiveness of therapeutic community treatment. Lees, 1999, but several of the included studies did not specifically identify the participants as suffering from ASPD. Nidotherapy is a formalized, planned method for achieving environmental change to minimize the effect of the patient's disorder upon themselves and others. The effectiveness of this treatment has not yet been established. Unlike most other therapies, it aims to fit the immediate environment to the patient rather than change the patient to cope in the existing environment. So, needle therapy, unlike most other therapies, aims to fit the immediate environment to the patient rather than change the patient to cope in the existing environment. Tyrer, 2007. Whilst the eventual outcome of needle therapy is environmental manipulation, it may be regarded as a psychological intervention in that it relies upon first developing a psychological understanding of the person's strengths and difficulties. From this psychological formulation, there follows goal setting, from which flows the necessary changes in the person's physical and social environment. Tyrer, 2005a. So from this psychological formulation, there follows goal setting, from which flows necessary changes in the person's physical and social environment. Tyrer, 2005a. That's interesting, because I do understand that the nature and nurture debate, or it's not a debate anymore, both of those come together to work for an individual in the first place. So whether someone changes their nature or changes their nurture, the environment in which they're in, or themselves, they're both intertwined. So it just seems like bidirectional effects either way you look at it. Why it is important to do this review. Antisocial personality disorder is an important condition that has a considerable impact on individuals, families, and society. Even by the most conservative estimate, ASPD appears to have the same prevalence in men as schizophrenia, the condition that receives the greatest attention from mental health professionals. Furthermore, ASPD is associated with significant costs, rising from emotional and physical damage to victims, damage to property, use of police time, and involvement of the criminal justice system and prison services. Related costs include increased use of healthcare facilities, lost employment opportunities, family disruption, gambling, and problems related to alcohol and substance misuse. Home Office, 1999, Myers, 1998. In one study, the lifetime public service costs for a group of adults with history of conduct disorder, of which one study of which 50% will go on to develop ASPD, were found to be 10 times those for a similar group without the disorder. Scott, 2001. ASPD is closely associated with criminal offending, and any intervention that seeks to improve the outcome of ASPD is also likely to impact upon this offending. Ayos, 2001, reported that for some crimes, especially those involving violence, the cost benefits in favor of intervention are often considerable, as the cost of these types of crimes are often very high. Despite this, there is currently a dearth of evidence on how best to treat people diagnosed with antisocial personality disorder, and to date, the few reviews that have been carried out have been inconclusive and hampered by poor methodology. These issues were highlighted in Dolan and Coid's, Dolan 1993, extensive review of the treatment of psychopathic and antisocial personality disorders. Unfortunately, the challenge to produce high-quality research in this area does not appear to have been fully taken up by the research community. This led a recent review of treatments for severe personality disorder by the United Kingdom's Home Office, Warren, 2003, to wryly comment that despite the 1,600 copies of Dolan and Coid's review having been purchased by clinicians, academics, and institutions, the methodological issues which were clearly set out in that review appear not to have been taken on board by the scientific community or those who fund research. Similarly, the recently published NICE clinical guidelines, that's NICE, all caps, Clinical Guidelines on Treatment of ASPD, NIH-CE 2009, page 5, commented that there were significant limitations to the evidence base, notably a relatively small number of randomized controlled trials, RCTs, of interventions with few outcomes in common. It is hoped that there will now have been additional good quality studies to address this important topic. Furthermore, a Cochrane review of psychological treatments for ASPD will highlight areas where more work is needed and hopefully stimulate research interests. Objectives. This review aims to evaluate the potential beneficial and adverse effects of psychological interventions for people with antisocial personality disorder. Methods. Criteria for considering studies for this review. Types of studies. Controlled trials in which participants have been randomly allocated to an experimental group and a control group, where the control condition is either treatment as usual, waiting list, or no treatment. We included all relevant randomized controlled trials, with or without blinding the assessors, and published in any language. Types of participants. Men or women 18 years or over with the diagnosis of antisocial personality disorder defined by any operational criteria such as DSM-4 or Antisocial Personality Disorder as defined by operational criteria such as the ICD-10. We included studies of people diagnosed with comorbid personality disorders or other mental health problems other than the major functional mental illnesses. For example, schizophrenia, schizoaffective disorder, or bipolar disorder. The decision to exclude persons with comorbid major functional illness is based on the rationale that the presence of such disorders and the possible confounding effects of any associated management or treatment might obscure whatever other psychopathology, including personality disorder, might be present and make it more difficult to evaluate the potential effect of any intervention. We placed no restrictions on setting and included studies with participants living in the community as well as those incarcerated in prison or detained in hospital. Types of interventions. We included studies of psychological interventions, both group and individual based. This included but was not limited to interventions such as number 1, behavior therapy. Number 2, cognitive analytic therapy. Number 3, cognitive behavioral therapy. Number 4, dialectic behavior therapy. Number 5, group psychotherapy. Number 6, mentalization-based therapy. Number 7, Nido therapy. Number 8, psychodynamic psychotherapy. Number 9, schema-focused therapy. Number 10, social problem-solving therapy. And number 11, therapeutic community treatment. Psychological interventions were subclassified into single modality and complex psychological interventions. Single modality psychological interventions are those that only involve one specific type of intervention. Such interventions include cognitive analytic therapy and cognitive behavioral therapy. Complex psychological interventions are those that involve more than one modality of treatment, for example, group therapy plus individual therapy, and include dialectical behavior therapy and psychodynamic psychotherapy with partial hospitalization. Campbell, 2000. We included studies of psychological interventions where medication was given as an adjunctive intervention, but reported separately any studies where the comparison is between a psychological and a pharmacological intervention. Studies comparing two or more different therapeutic modality groups but without a control group are not included in the review. Types of outcome measures. Primary and secondary outcomes are listed below in terms of single constructs. We anticipated that a range of outcome measures would have been used in the studies included in the review. For example, aggression may be measured by self-report instrument or by external observer. Primary outcomes: aggression, reduction in aggressive behavior or aggressive feelings. Continuous outcome, measured through improvement in scores on Aggression Questionnaire, AQ, BUS 1992. The Modified Overt Aggression Scale, MOAS, Malone 1994, or similar validated instrument, or as number of observed incidents. Reconviction, measured as overall reconviction rate for the sample, or as mean time to reconviction. Global state functioning. Continuous outcome, measured through improvement on the Global Assessment of Functioning, Numeric Scale, GAF, APA 2000. Social functioning. Continuous outcome, measured through improvement in scores on the Social Adjustment Scale, SAS, SR, Wiseman 1996, the Social Functioning Questionnaire, SFS, 2005B, or similar validated instrument. Adverse events, measured as incidence of overall adverse events and of the three most common adverse events. Dichotomous outcome, measured as numbers reported. Secondary outcomes, quality of life, self-reported improvement in overall quality of life. Continuous outcome, measured through improvement in scores on the European Quality of Life Instrument, EuroQOL Group 1990, or similar validated instrument. Engagement with services. Health-seeking engagement with services measured through improvement in scores on the Service Engagement Scale, SES, Tate 2002, or similar validated instrument. Satisfaction with treatment. Continuous outcome, measured through improvement in scores on the Client Satisfaction Questionnaire, CSQ-8, Atkinson, 1982, or similar validated instrument. Leaving the study early, measured as proportion of participants discontinuing treatment. Substance misuse, measured as improvement of the Substance Use Rating Scale, patient version. SURS-P, Duke, 1994, or similar validated instrument. Where possible, drug misuse outcomes and alcohol misuse outcomes were differentiated. Employment status, measured as number of days in employment over the assessment period. Housing accommodation status, measured as number of days living in independent housing accommodation over the assessment period. Economic outcomes. Any economic outcomes, such as cost effectiveness, measured using cost-benefit ratios or incremental cost-effectiveness ratios, ICERs. Impulsivity, self-reported improvement in impulsivity, continuous outcome, measured through reduction in scores on the Barrett Impulsivity Scale, BIS, Patent, 1995, or a similar validated instrument. Anger, self-reported improvement in anger expression and control, continuous outcome, measured through reduction in scores on the State Trait Anger Expression Inventory, Staxi number 2, Spielberger 1999, or similar validated instrument. Whilst acknowledging the nature of the disorder can lead to difficulty in long-term follow-up of individuals with ASPD, we aim to report relevant outcomes without restriction on period of follow-up. We aim to divide outcomes into immediate, within 6 months, short-term, greater than 6 months to 24 months, medium-term, greater than 24 months to 5 years, and long-term, beyond 5 years, if there were sufficient studies to warrant this. The next part is search methods for identification of studies, and that's on page 13 of 176 from the article Psychological Interventions for Antisocial Personality Disorder by Cochrane Database Systematic Review, published in 2010. I'm going to go ahead and read the next part after this video. I don't want to make these videos too long. Thank you for your time.